Hello everyone, David Wilson here from Dr. Stem Cells again, and in today's video we're also going to be looking at, this is the next video in our series, as we look at the American Academy of Orthopedic Surgeons and their technology overview for PRP for knee osteoarthritis. Now, in the last video I didn't mention this, but it's worth just zooming in here and taking a quick look at their disclaimer. The technology overview was prepared using systematic review methodology and summarizes the findings of studies published as of August 25th, 2021. On the use of platelet-rich plasma for treatment of knee osteoarthritis. As a summary, this document does not make recommendations for or against the use of PRP. It should not be construed as an official position of the AAOS. Readers are encouraged to consider the information presented in this document and reach their own conclusions about PRP for treatment of knee osteoarthritis. I think this is a very good point. While I'm presenting this data as well, I'm not telling you what you ought to be doing as patients nor as doctors. I expect that medical professionals can make their own opinions and summarize the data themselves, but this is a very useful tool to be able to look at the data that's already being presented. So let's go down today to today's topic. We're down to page 5, at least according to the numbering of the system, it's page 5. I think it's page 7 if you actually look at the number of pages we looked at. But anyway, our last video we looked at PRP against placebo, and we found that there were some high quality studies there showing that PRP was effective when compared to placebo. Now, you would hope so, but of course there's no guarantee. Now we have some data that suggests that that is the case. Now, today's video is actually about PRP versus hyaluronic acid. There were 18 high quality studies and 7 moderate quality studies evaluating PRP versus hyaluronic acid injections for patients with osteoarthritis of the knee. Now, I'm just going to stop there and highlight this paper, Bansal 2021. Let's just, if we go here, Bansal, and let's go down to the references section. Not that this is of particular import maybe, but we're very pleased that this is a paper we have helped publish. Jeremy and myself were involved in the publication of this paper with Dr. Bansal, and this is one of the high quality studies that are named here in this for looking at PRP versus hyaluronic acid. So let's go back to where we were. We were at page 5, page 6 here, PRP versus hyaluronic acid. There were 18 high quality studies and 7 moderate studies. And they're listed here. Now, the 18 high quality studies evaluated the outcomes of 1,777 patients total in both PRP and hyaluronic acid groups. PRP showed more improvement than hyaluronic acid in patient-reported outcomes. Now, patient-reported outcomes are your subjective reported outcomes. We can look again at WOMAC. We can flash that up here on the screen, and you'll be able to see a little bit of the standard WOMAC questionnaire. 9 out of the 12 high quality studies reported that there were improvements. However, 3 high quality studies found no difference between PRP and hyaluronic acid. Patients treated with PRP also had improved VAS, visual analog score, pain scale scores, and in 6 of the 9 high quality studies they reported that measure. So again, you can see 2 of the 9 high quality studies reported that VRS pain score showed no significant difference between PRP and HA, and the final study found worse PRP scores with the VAS. So it's certainly an interesting summary. Now, let's come down to what they are suggesting here. So, PRP demonstrated a benefit over hyaluronic acid for patient-reported outcomes related to knee function in this case. Now, this is interesting because in the PRP versus placebo group, there were not particularly good function outcomes, but in this case, we actually see better functional scores than the hyaluronic acid. This may have just to do with the small cohort groups that are used when they're studied. Some people will have better function outcomes and others won't. Maybe the PRP versus placebo papers were not in particularly, the groups maybe just didn't have that potential, but we don't know. PRP showed improvement in IKDC in 6 of 6 high quality studies that looked at this outcome, and better WOMAC function subscores in 8 of 10 that looked at this outcome. So 2 high quality studies showed no significant difference between WOMAC, and that's these 2 papers here. Only 4 of the high quality and 2 moderate quality studies reported on adverse effects. 3 high quality studies found difference in adverse effect between PRP and HA and also had mixed findings. 1 study compared the efficacy of single PRP versus hyaluronic acid using ultrasound assessment for synovial hypertrophy, synovial vascularity, and knee effusion at 6 months. And their results suggested that patients treated with PRP had significantly less synovial vascularity, synovial hypertrophy, and knee effusions. However, another study reported increased rates of minor complications due to the injection of PRP. And a 3rd study found an increased incidence of pain after injection. Now, I would say this is absolutely correct. our clinical data, just even in-house, is that PRP injections tend to be the most painful injections we do. I think partly that is because when you look at how your platelet in the normal healing cascade, how the platelet breaks down, if you remember your biochemistry, and you think back to how the platelet has the membrane includes arachidonic acid. The arachidonic acid will be activated and broken down using the COX pathway. And as you do that, you develop prostaglandins, and prostaglandins actually induce and help with healing. Well, as we look at that, that's going to induce pain, it's going to induce swelling, it's going to induce redness, increased vascularity. So the platelets definitely can cause acute pain and discomfort at the injection site. So we have actually begun mixing our PRP with a little bit of xylocaine or lidocaine. So we don't give the anesthetic first, because I feel like that always impairs the view with your ultrasound, because now you've got an extra liquid you've just injected in. But instead we mix it with the PRP, so we make our PRP extra concentrated and then dilute it down a little bit so that we end up with a 7-time concentrate at the end. So back to the paper then. In summary, PRP compared to hyaluronic acid resulted in improved patient-reported outcomes in the majority of high-quality studies. It's possible that the PRP or patient features that dictate who might do well with PRP treatment explain the heterogeneous and sometimes contradictory findings. I also think that one of the reasons that you get different findings is that there are large differences in what is actually called PRP, but we'll talk about that in a moment. And further work to document these treatments and recipient characteristics are needed, and I would agree with that summary. Now, the reason I mentioned that I think it's important to talk about dose, and I've been doing this a little bit, maybe too much. You can let me know if you think I'm talking about this too much in these video series, but dose is so important, and I know for a fact that there are papers being circulated, there are people talking about information, they're saying, oh, you could use our system, a 5-minute spin, you get a 1.6 to 2.4 times concentrated PRP, that's enough. I disagree with that. We do need more studies within this field to try and finally define PRP as it should be used in a clinical setting. But my opinion is that people should be giving a PRP that is between 5 and 7 times the body's concentration of blood, not this sort of the weaker concentrates. Now, those weaker concentrates do have their place. They can be used widely in cosmetics. We've had extremely good results by doing some cosmetic work on patients with just very weak PRP, probably even actually what you can just call plasma from before. So 1.5 to 2 times concentrate and still getting the cosmetic results. But from a musculoskeletal perspective, from joint injury, arthritis and so on, I do think that patients should be given a stronger dose. Finally then, we just want to have a quick look at the table here summarizing what was actually looked at, and it's a lovely way to kind of just get your eye over the data. So on the left here you have the high quality studies are here, the moderate quality studies over here, and as we look down through this you can then see each of the scores that were looked at. So what score was looked at and how did that stack up? So as you can see, WOMAC is probably one of the easiest scores to look at because this is a very good and very useful standardized knee and hip evaluation tool. And you can see that across the board, the majority of studies were showing improvement. The ones which looked at it, and 4 did not show improvement. Now, of those 4, 1 was a moderate quality, and you can see then that the rest of the studies showed improvement. Now, we also have WOMAC here, total with 30% decrease, 50% decrease, and so on, looking at this. But let's scroll on down. Functional scores here. And as we come down here, we see that your IKDC, which are a very good standardized knee function score system, they show improvement in the ones which tested it. WOMAC function, WOMAC stiffness leans towards improvement, but kind of a 50-50 split almost, not quite, but almost. And then as you go down, you can see all these other ones where we've looked at different scores, some showing improvement, some showing less improvement or no improvement. Pain scores, I would say tendence to improvement, but again, when you start to look at these papers, here's one in particular that showed that people had more pain after the injections. It seems to depend a lot on the time that these questionnaires are taken as well. So if you take a questionnaire within the first 2 to 4 weeks, I think you're going to find people report no difference or worse pain. But if you wait 3 to 6 months, you're going to have improvements. And that would also fit with our understanding of the healing cascade and how much time it takes. Quality of life, you can see only a few papers really looked at this. The SF36 vitality, mental component, and so on. You can see that, again, in this paper, the 2015 paper, there were improvements, statistically significant improvements in most of the sections, but not all. But here we have a paper, and it showed that there was little to no quality of life improvement, this segue score. Adverse events, again, very interesting. No significant difference in infection, low-grade fever, pain. This is not something you would expect a lot of. Effusion, one paper showed increased effusion. Any adverse effect, no significant difference here in this one. We'll be doing more of these videos. We're going to continue. The next one will be PRP against a steroid. I hope this is useful and something very important or something you can learn from. Let us know. We'll actually be doing our PRP workshop where you can learn everything from A to Z about PRP, how to create it, how to make it in your own lab using generic equipment so you don't have to be bound to the whims of these manufacturers, and so you can make your own concentrations and inject it at your leisure, make the dose and the volume you wish so that you can treat whatever indication you're looking for. We'll have links to that also, and I hope to see you there. Otherwise, look forward to this next video. It's going to be PRP versus corticosteroids, and that's an interesting discussion in and of itself. See you next time. Bye-bye.